Welcome back. We are now going to thoracic surgery. So in cardiac surgery, we have two parts. One is cardiac surgery, another is thoracic part. And in this thoracic surgery, we are going to first discuss on mediastinal masses. The mediastinal masses. So mediastinal masses. So the mediastinum or the thoracic cavity is divided into three parts. This is heart. This is vertebra. Okay, this is diaphragm. So now you have three parts in the mediastinum. So this is anterior mediastinum, this is middle mediastinum, this is posterior mediastinum, this is superior. So superior mediastinum. Superior mediastinal masses we are not discussing here. In this superior mediastinum, we get thyroid swelling, retrosternal thyroid swelling, parathyroid swelling. Thyroid swelling, retrosternal goiter extends into the superior mediastinum. Parathyroid swellings can arise in the superior mediastinum. Sometimes the thymoma mass can be extending towards superior mediastinum. But in Bailey and Love, they are explaining more about these three mediastinal masses only: anterior, middle, posterior. What is the most common mediastinal mass as a whole? Most common mediastinal mass as a whole from Bailey and Love answer is thymoma. Though it is wrong, we have to follow Bailey and Love for national board exams. So actually the correct answer is most common is neurogenic tumors. The most common actual answer is neurogenic tumors from Sabiston, but Bailey and Love the answer given is thymoma. So since the national board examiners usually take questions from Bailey and Love only, not from Sabiston, so for national board exams follow thymoma, and for AIMS and other institute exams you can go with neurogenic tumors. Neurogenic tumor is actually correct answer. Okay, so this is a long run controversy. This is not for the past. There are certain mistakes in Bailey and Love which we have to follow blindly because the examiners will follow blind questions from Bailey and Love. Okay, so anterior mediastinal masses. What are the masses present in anterior mediastinum? Here we have thymoma, lymphoma, germ cell tumors, and the thyroid and parathyroid tumors can also be present. Masses can also be present. Thyroid, parathyroid masses can extend from superior to anterior mediastinal mass, and we have mesenchymal tumors. So these are the anterior mediastinal masses: thymoma, lymphoma, germ cell tumor, thyroid mass, parathyroid mass, and mesenchymal tumors. In anterior mediastinum, the most common is thymoma. In middle mediastinum, the most common lesion is cyst. Cyst is the most common lesion in the middle mediastinum. Cyst, like what are the cysts? Like pericardial cyst, bronchogenic cyst. I'm going to discuss about bronchogenic cyst, pericardial cyst. All cysts are seen in middle mediastinum, and vascular aneurysms. So major vessels are seen here only. So aneurysms are seen in middle mediastinum. Aneurysms, lymph node masses, presence of lymph node masses. So the mesenchymal tumors, and ectopic pheochromocytoma. So naturally, ectopic pheochromocytoma will be seen along the sympathetic chain. So this is ectopic pheochromocytoma is also seen in this mediastinum. Cyst, aneurysm, lymph node mass, mesenchymal masses, ectopic pheochromocytoma. So in middle mediastinum, the most common is cyst. In posterior mediastinum, the most common is neurogenic tumors, meningocele. Yes, mesenchymal tumors. So mesenchymal tumors happen everywhere. Mesenchymal tumors, pheochromocytoma, and lymphoma. All these are posterior mediastinal masses, and in posterior mediastinum, the commonest is neurogenic tumor. So the commonest masses in each mediastinum, please don't forget. In anterior mediastinum, it is thymoma. In middle mediastinum, it is bronchogenic cyst. In posterior mediastinum, it is neurogenic tumors. Okay, please don't forget these points. So pheochromocytoma is present in middle and posterior. Mesenchymal tumor is present in all mediastinum. All these are some interesting points you should not forget in mediastinal masses. So in mediastinal masses, I'm going to first start my discussion on the first topic of thymoma. Bailey now has explained very well about thymoma. Please don't forget the thymoma. So thymoma is the most common neoplasm of thymus. It is the most common neoplasm present in thymus, and thymoma is most commonly seen in anterior mediastinum. Most common location is anterior mediastinum, and it is common in the age group of 40 to 60 years. 40 to 60 years, it is commonly seen. And thymoma, interestingly, it has a well-defined fibrous capsule. If this is thymoma, it has a well-defined fibrous capsule around it. It is surrounded by a well-defined fibrous capsule. Okay, like a thyroid tumor, the capsular animation is taken into account in staging. So there is a well-defined fibrous capsule, and the types of thymoma are lymphocytic type, epithelial type, lymphocytic thymoma, epithelial thymoma, and mixed type. Mixed type is most common. Lymphoepithelial type or mixed type is most common type of thymoma. So please don't forget they have a well-defined capsule. The classical clinical feature of thymoma is usually they are asymptomatic. They are not diagnosed. Usually they are asymptomatic. Okay, they are detected incidentally on an X-ray chest. So usually they are asymptomatic and detected on an X-ray chest. There is a mass in the anterior and extending to the superior mediastinum. If at all it is going to cause symptoms, it can cause dysphagia, it can cause dyspnea, it can cause SVC syndrome, and it can cause paraneoplastic syndrome. This is an MCQ here. So the paraneoplastic syndrome is very common in thymoma. The most common paraneoplastic syndrome is what? What is the most common paraneoplastic syndrome in thymoma? It is myasthenia gravis. Please don't forget, it is myasthenia gravis is the most common paraneoplastic syndrome in thymoma. So what are the other paraneoplastic syndromes? Paraneoplastic syndromes of thymoma can be the following. The following are the paraneoplastic syndromes. Please don't forget, myasthenia gravis is the most common. Okay, myasthenia gravis is most common. Neuromuscular dystrophy. What are the other things? Neuromuscular dystrophy, myotonic dystrophy. So neuromuscular dystrophy, myotonic dystrophy, myasthenia gravis is the most common type. And what are the other types? The other types include cytopenias. It can cause thrombocytopenia, pancytopenia, all those things. Red cell aplasia, decreased hypogammaglobulinemia, and erythrocytosis, nothing but polycythemia. Sometimes the RBC count can increase, polycythemia or erythrocytosis. So the blood-related problems, these are the blood-related problems. This is muscle-related problems, and there is generalized orthopedic problems like rheumatoid arthritis, SLE, polymyositis, sarcoidosis. So SLE, rheumatoid arthritis, polymyositis, sarcoidosis. So these are orthopedic problems. So muscle problem, orthopedic problem, and blood vessel problems are seen. The three paraneoplastic syndrome seen in thymoma. Please don't forget thymoma. And thymoma is diagnosed by the following investigation. Investigations to diagnose thymoma. So please don't forget the investigation of choice for diagnosis of thymoma is CT scan. So investigation of choice is CT scan. If you want to make a definitive diagnosis, because the major differential diagnosis here is lymphoma. We will have a great confusion with lymphoma. Whether you want to know whether it is like lymphoma or thymoma, we have to do tissue diagnosis. So tissue diagnosis has to be done if you want to confirm it is thymoma, or else we have to do cytokeratin. Cytokeratin is best marker for thymoma. Cytokeratin is the best marker for thymoma, tumor marker for thymoma. Cytokeratin will be elevated. So in CT scan, how to differentiate thymoma from lymphoma? When I'm taking a CT scan in the anterior mediastinum, there is a huge mass like this. How to know this is thymoma or lymphoma? If it is a lymphoma, they always have associated lymphadenopathy. There won't be single mass. It will be associated lymphadenopathy will be present. Associated lymph node enlargements will be present. Whereas thymoma is usually a well-defined solitary lesion with a well-defined capsule. Thymoma is usually solitary. Thymoma appear as a solitary lesion, whereas lymphoma has a associated lymph nodes. So please don't forget this point. And there is a staging system for this known as Masoka staging system. Masoka staging system. So don't need to remember the in-depth of staging system. Just I'm telling you an outline. 1, 2, 3, 4A, 4B. This is Masoka staging system. So one is macroscopically, it is a well-encapsulated lesion like this. Macroscopically, it's a well-encapsulated lesion like this. Macroscopically, encapsulated lesion. And when you examine by microscopy, no microscopic invasion. Well-defined capsule seen on microscopy, there is no microscopic invasion present. In stage 2, there is a well-defined capsule. There is a well-defined capsule, but it has infiltrated into surrounding fatty tissue and pleura. Fat and pleura is infiltrated, and there is definitely microscopic invasion present. Okay, microscopic invasion is present. So there is no microscopic invasion, well-defined, localized is 1. 2 is infiltrating into fat and pleura with a microscopic invasion is present. 3 is a macroscopic invasion. Grossly, we can see it is infiltrating lungs, pericardium, great vessels. All these are directly infiltrated. Macroscopically, we are seeing it is infiltrating. So 4A is pleural mets, or pericardial mets. Pleura and pericardium full of mets like this. Full of mets in the pleura and pericardium. Lymphogenous or hematogenous mets. Lymph or hematogenous mets. It has spread away from the mediastinum. Hematogenous mets are present. So this is Masoka staging system. Masoka staging system is a staging system for thymoma. So please remember, 1 is confined to the capsule, no microscopic margin. 2 is infiltrating into surrounding fat and mild pleural infiltration. Microscopic invasion is present in 2. 3 is macroscopically, it has invaded the lungs, pericardium, great vessels. Peritoneal and diffuse peritoneal and pericardial dissemination is 4A. 4B is gone to hematogenous. So management of thymoma, if it is symptomatic and causing issues, always we must do sternotomy. We must do sternotomy and we must remove the thymus. Thymectomy is done. Sternotomy and thymectomy is done. By a medial sternotomy, thymectomy should be done. For large thymomas more than 5 cm size, thymectomy should be followed by chemotherapy is also done. So for more than 5 cm, we should do thymectomy plus chemotherapy. For patients who are having myasthenia gravis, the major problem of myasthenia gravis, along with thymectomy, we have to also give anticholinesterase drugs. Thymectomy plus anticholinesterase drugs are given. We have to give anticholinesterase drugs. So this procedure is nowadays, instead of doing a sternotomy and thymectomy, now this can be done by help of video-assisted thoracoscopic surgery. Thymectomy is done nowadays. So VATS thymectomy is done nowadays. Instead of opening the sternum and going inside, we can do a VATS thymectomy can be done. So one of the important mass, anteromediastinal mass, thymoma. Please don't forget, in thymoma, please don't forget, it is having a well-defined capsule and it is having a staging system known as Masoka staging system. So then coming to the middle mediastinum, the most common mass is bronchogenic cyst. Any cyst is common in the middle mediastinum, and one of it is bronchogenic cyst. What is bronchogenic cyst? It is a congenital lung lesion which arises from anomalous development of foregut. It is anomalous development of foregut. It is due to anomalous development of foregut or tracheobronchial tree. From the foregut it can develop, or from the tracheobronchial tree it can develop. It can arise in 2 places. It can happen in either in the mediastinum or it can happen into the parenchyma, pulmonary parenchyma, which is common. Bronchogenic cyst happening in the pulmonary parenchyma is common, or in the mediastinum is common. It is most common in mediastinum. Around 85% is seen in mediastinum. Only 15% is seen in pulmonary parenchyma. So when it is present in the mediastinum, no communication seen with the tracheobronchial tree. Whereas if it is in the pulmonary parenchyma, tracheobronchial communication is present. So tracheobronchial communication is present if it is present in the pulmonary parenchyma. Which side will you get commonly? If it is in the pulmonary parenchyma, most common in right lobe, right lung, in the lower lobes. If at all the bronchogenic cyst is seen in the right lobe, lower lungs, right lower lungs it is seen. Okay, so bronchogenic cyst can cause the following complications. So bronchogenic cyst, why we should discuss more about this is because this can rupture. It can rupture resulting in pneumothorax. It can rupture resulting in pneumothorax. It can cause atelectasis, compression of one lung. It can go for infection. And very important is this can go for malignant transformation. There is risk of malignancy is also present. So when there is communication with the tracheobronchial tree, they can also develop hemoptysis. So these are the complications of this bronchogenic cyst. And bronchogenic cyst, whenever you find a bronchogenic cyst, treatment is excision. The excision of the cyst is advised by VATS method. So bronchogenic cyst is removed by VATS method. So this is one another middle mediastinal mass. Bronchogenic cyst is a middle mediastinal mass, and there is one more mediastinal mass known as lung sequestration. This is a very commonly asked Ames question, lung sequestration. I am discussing some of the important mediastinal masses. So the next important mediastinal mass is lung sequestration. What is lung sequestration? So lung sequestration is a sequestration. It's a small tissue of lung containing. It's a small tissue of lung containing bronchioles. It is containing bronchioles, alveoli. Everything is present. It is containing bronchioles, alveoli. Everything is present inside, and it is receiving blood supply from. Usually, where is the main blood supply to the? What is the main blood supply to the lungs? Mainly from pulmonary artery, but here it is from aorta. The main blood supply of sequestrated part of lung is aorta. So lung sequestration is a sequestration of normally developed lung. Normally developed lung. It is normally developed like a lung containing bronchioles, alveoli. The main difference between normal lung and lung sequestration is instead of pulmonary artery, here aorta is supplying this. So there are 2 types of lung sequestration. Please don't forget there are 2 types of lung sequestration. They are known as intralobar sequestration. Intralobar sequestration. Intralobar sequestration like this. Inside the lung, it is intralobar sequestration. Another sequestration is the normal lungs is present. There is a sequestration outside. There is a sequestration outside like this, outside of the lungs. So this is extralobar sequestration. So intralobar sequestration is within the lung parenchyma. Extralobar is outside the lung parenchyma. So intralobar sequestration is 75%. This is most common. Extralobar is only 25%. Extralobar is only 25%, and it is also known as another name for extralobar sequestration is Rokitansky lobe. Rokitansky lobe is another name of extralobar sequestration. So the main difference between intralobar and extralobar is intralobar has communication with tracheobronchial tree. Extralobar has no communication with tracheobronchial tree. So intralobar sequestration, since it is having communication with tracheobronchial tree, it can get infection, it can get abscess, it can get hemoptysis. All problems can happen in this. So since intralobar sequestration is associated with acute bronchial communication, all complications can happen. Extralobar sequestration will not develop these complications, but it is associated with congenital diaphragmatic hernia. It is usually associated with congenital diaphragmatic hernia. So where did I tell you the bronchogenic cyst is common in right lower lobes. It is common in right lower lobes, whereas intralobar sequestration is common in left lung. So it is most common in left lung. Intralobar sequestration is common in left lung. So both this intralobar and extralobar sequestration are going to receive the blood from aorta. And where are they going to drain? So extralobar sequestration drains into 80% of the time into azygous vein and 20% into pulmonary vein, whereas this guy intralobar sequestration 100% drain into pulmonary vein. So 100% drain into pulmonary vein. So extralobar sequestration 80% into azygous vein, 20% into pulmonary vein. Please don't forget about these two sequestrations, intralobar and extralobar sequestration. So intralobar sequestration and extralobar sequestration is asked already in the exam. So intralobar sequestration is most common 75% of the time. Extralobar is only 25%. It is associated with Rokitansky lobe and there is no communication seen. It is associated with congenital diaphragmatic hernias. So the drainage is into 80% time into azygous vein rather than pulmonary vein in extralobar, whereas in intralobar 100% into the pulmonary vein. Okay. So in last chapter we discussed about chyluria in lymphedema chapter. Now it is chylothorax. Sometimes the patients may develop chylothorax like a pleural effusion. There is a chylothorax. And when we are examining the fluid is milky white in color. And when we examine the triglyceride level in the fluid, it is more than 110 milligrams per deciliter. Okay, the triglyceride level is more than 110 milligram per deciliter or more than 1.2 millimoles per liter. So the triglyceride level is used to say this is a chylothorax. That is full of triglycerides, more than 110 milligrams per deciliter. So what I'm going to do now? Now I'm going to first manage chylothorax. Usually this follows a malignancy or surgery. So chylothorax is a complication of malignancy or some surgery like esophagectomy, some bad surgery, something we have injured the thoracic duct inside and that causes chylothorax. So initially we manage them by fat-free diet. Fat-free, or if you want to give fat, medium chain triglycerides are given. We will give protein diet. So when you give this and if you give fat-free TPN and manage these patients, most of them will heal. Most of them will heal with this conservative management. What is the indication of surgery? When you have to go and intervene? When there is no improvement. When there is no improvement after 5 days. No improvement after 5 days of conservative treatment, number one. We are doing conservative management after nil oral fat-free diet or giving a fat-free TPN, everything. Chyle loss coming out is more than 1500 ml and it is non-healing for more than 2 weeks. Even after doing all this thing, it is not healing for more than 2 weeks. In these cases, we will go and intervene at the level of poirier triangle point. We have to go and ligate. We have to go inside and ligate at the level of poirier triangle. What is this poirier triangle? It is bounded by the following. It is bounded by arch of aorta, left subclavian artery, and the vertebra posteriorly. So in this area, there is a triangle here bounded by left subclavian artery, arch of aorta, vertebra. So please remember poirier triangle. It's expected MCQ for aims. Poirier triangle bounded by left subclavian artery, arch of aorta, and vertebra. This is a triangle. This is a triangle in which we can find out what do you find out here? The thoracic duct going and draining into the junction of left subclavian vein and internal jugular vein. This is the place where it drains into left subclavian vein plus internal jugular vein junction at the brachiocephalic level. It is draining here in this place. So we will go here and ligate this. So this is one place where we ligate in a chylothorax. In a poirier triangle is one place where we ligate the thoracic duct. So poirier triangle is the old MCQ after NEET SS as well as NEET PG, in which we ligate left subclavian or internal jugular vein at the level of junction of arch of aorta, left subclavian artery, and the vertebra. In this case, we have to go and ligate. Okay. So these are the basic points I want to remember in this topic. Please don't forget these points. Okay. So from the points. So next we are going to discuss in this topic on lung tumors. So lung tumors can be divided into benign and malignant. Benign tumors and malignant tumors. So in benign tumors, the most important and the most common benign tumor is pulmonary hamartoma. Pulmonary hamartoma is the most common benign tumor. Most common benign tumor is pulmonary hamartoma. It is most common in males. What is the classical MCQ point in pulmonary hamartoma? Even in X-ray, it can look like a popcorn calcification. So we all very well know fibroadenoma looks like popcorn calcification. Here also it looks like a popcorn calcification. And hamartomas are most commonly located peripherally. They are located peripherally. So please don't forget lung tumors. Lung tumors can be divided into benign and malignant. In malignant, we are going to discuss about bronchogenic cancers in detail in this chapter. Bronchogenic cancers in detail we are going to discuss. We are not going to discuss about the mets. Lung mets are more common than bronchogenic cancer. Metastasis is more common in the lungs. But I'm going to discuss in this chapter from Valiant Love on bronchogenic cancers. So, okay, so now let us discuss one by one the various points of the captain of all men of death, bronchogenic cancer. Bronchogenic cancer, full of MCQ points. This chapter is full of MCQ points. So this is the most common primary malignant tumor. So what is the other malignant tumor in the thorax? Apart from bronchogenic cancer, we have malignant mesothelioma. The other malignant tumor is malignant mesothelioma, arising from the pleura. So malignant mesothelioma and bronchogenic cancers are the two common malignant tumors. The most common primary malignant tumor in mediastinum is bronchogenic cancer. It is most commonly seen in lung, high lung. So this is the most common visceral cancer all over the world. Most common visceral cancer among your body. Among the various cancers, most common visceral cancer. It is the most common cause of death due to cancer. Due to cancer, this is the most common cause of death. Captain of all cancer death is due to bronchogenic cancer. In GIT, it is stomach. Overall, it is lung. In GIT, it is stomach cancer is the captain of GI cancers. Overall, the captain is bronchogenic cancers. Bronchogenic cancer causes death overall. Okay, now bronchogenic cancers. We'll discuss the points now. In bronchogenic cancers, what are all the risk factors? The main risk factor any child will tell. Even if you ask a child, they will tell you it is smoking. Smoking is the main risk factor for bronchogenic cancers. Air pollution. Smoking, either an active smoker or a passive smoker will get this. Air pollution, asbestos, nickel exposure. So asbestos, nickel exposure. Previous scars in lungs can lead to adeno cancer. Radiation radiation, and certain mutations. Like what are the mutations which can cause cancer? KRAS, BCL2C, Mike. Among this, KRAS is the most common mutation causing adeno cancer. So KRAS, BCL2C, Mike are the various mutation abnormalities causing cancer. Among this, KRAS is the most common to cause adeno cancer. Please don't forget these risk factors. Main risk factor is smoking. So now we are coming to the most important aspect of this chapter, pathological types. So please understand, next 10 minutes very important for your exams. Pathological types are divided into small cell cancer, also known as oat cell cancer, and divided into non-small cell cancers, small cell and non-small cell. In non-small cell we have the following cancers: adeno cancers, squamous cell cancers, large cell cancers, bronchoalveolar cancers are all coming under non-small cell cancers. So bronchoalveolar cancer is a cancer which spreads by air. It spreads by air. Therefore you can see satellite tumors are present. It spreads by air. The aerosols it spreads. Bronchoalveolar cancer. Therefore you can get satellite nodules in the lungs. So bronchoalveolar cancer not much discussed. So let us see what are the classical, why we are dividing them into small cell and non-small cell. The basic point is small cell cancer has high risk of METs. High risk of METs is present. They have poor prognosis. So please remember, small cell cancer has high risk of METs with a poor prognosis, and they respond to chemotherapy very good. Response to chemo is excellent in small cell cancers. Whereas in non-small cell cancers, the risk of METs is less and they have comparatively good prognosis and they have no response to chemo. So no response to chemotherapy. Non-small cell cancers have no response to chemotherapy. Only small cell cancers have response to chemotherapy. The salient points of non-small cell cancer, most common type is what? Most common type is adenocancers, adenocarcinomas. Adenocarcinoma is the most common type. Then most common type among smokers is squamous cell cancers. So undifferentiated type is large cell. Large cells are usually undifferentiated. Large cell cancers are usually undifferentiated cancers. So among these various cancers, who will have high amount of paraneoplastic syndromes? Small cell cancer produces increased paraneoplastic syndromes are present. Increased paraneoplastic syndromes are present in small cell cancer. This is a basic difference between these guys. Another important difference is small cell cancer is usually centrally located tumor like this, whereas non-small cell cancers are usually peripherally located cancers like this. They are usually peripherally located. Small cell cancers produce high metastatic lesions, high chances of METs. It produces METs to brain, bone, liver, adrenal, everywhere it will produce excessive METs, whereas non-small cell less risk of METs. Okay, there will be so much of paraneoplastic syndrome in small cell cancer, less paraneoplastic syndrome in non-small cell, and less risk of METs, but here it is high risk of METs. And the basic reason we divided them is small cell tumors have excellent response to chemo, non-small cell have no response to chemo. That is the main reason we differentiated them into small cell and non-small cell cancers. That is the main reason we have differentiated them into small cell and non-small cell cancers. So now coming to the discussion on clinical features. Clinical features of lung cancer, the most common symptom is cough. Cough, we come to you with a cough, dyspnea, chest pain, and hemoptysis. So dyspnea, chest pain, hemoptysis, cough. Cough is the most common symptom. They can present to you with a malignant pleural effusion. Presentation itself, they have malignant pleural effusion. Presents to you as malignant pleural effusion. The tumor is most common on the right lobe. Usually in the upper lobes. So the right lung, upper lobe is the most common site. Right lung, upper lobe is most common site. And if this patient is going to have hematemesis, the hematemesis source is usually from which artery? From the pulmonary vein, bronchial artery. Hematemesis, this question came in national board exam. Hematemesis source is bronchial artery. The source is from bronchial artery. The bleeding is usually from a bronchial artery bleed in a patient with hematemesis. And more important, you have to see for the clubbing. They will have clubbing. Clubbing will be present. And it is interesting point, it will resolve after lung resection, resolve after tumor excision. That's an interesting point. The clubbing which is present will resolve after tumor excision. And there will be hoarseness of voice due to recurrent laryngeal nerve involvement. There will be dysphagia due to esophagus involvement. There will be superior vena cava obstruction caused by small cell cancer. Small cell cancer causes superior vena cava obstruction. Another important paraneoplastic syndrome is Eaton-Lambert syndrome, like a myasthenia gravis. This patient may have Eaton-Lambert syndrome. It is also seen in small cell cancers. So please remember, these are the various features the patient presents to you: cough, dyspnea, malignant pleural effusion, clubbing, hoarseness, dysphagia, SVC obstruction in small cell cancers, Eaton-Lambert syndrome in small cell cancers are various presentations to hospital. Now let us discuss each tumors one by one. So let us discuss the commonly asked MCQ, Pancoast tumor, very commonly asked MCQ. So every year there will be at least a few questions in any exam from lung cancer. And this Pancoast tumor is nothing but a tumor located in the apex of the lung. It destroys the ribs. It destroys first and second ribs. It causes atrophy of hand muscles, and it causes Horner's syndrome. What is Horner's syndrome? That is ptosis, meiosis, and hydrosis. So ptosis, meiosis, and hydrosis. Horner's syndrome happens, atrophy happens, destruction of first and second rib happens. This Pancoast tumor is what tumor? It is usually a squamous cell cancer. Which causes this Pancoast tumor. Please remember, it is a tumor at the apex of lung. It is usually squamous cell cancer which causes this Pancoast tumor. Please don't forget Pancoast tumor. So let us discuss now about the squamous cell cancer in detail. Squamous cell cancers of lung. So very interesting. Some MCQs are there. Squamous cell cancer is the most common cancer in India. Most common cancer in India is squamous cell. Most common among smoking males is squamous cell cancer. Pancoast is a squamous cell cancer. Squamous cell cancer is usually centrally located. So what other tumor is centrally located? Small cell cancer also centrally located. Squamous cell cancer is centrally located. An interesting point is it can form cavity inside. Cavitational tumor. It can look like a cavity. An interesting point is this is having the best prognosis. Among all the lung cancers, this has best prognosis. Best prognosis is seen with squamous cell cancer. It produces ectopic ACTH, and therefore it produces hypercalcemia. It produces ectopic parathyroid hormone. So it produces ectopic parathyroid hormone. Therefore, there is hypercalcemia, hypophosphatemia seen. There will be hypercalcemia and hypophosphatemia seen in these patients. So ectopic parathyroid hormone produces hypercalcemia and hypophosphatemia. Treatment is surgical excision. We have to excise the tumor by surgery. Surgical excision is the best treatment. It is mainly producing ectopic parathyroid hormone production. Please don't forget, ectopic parathyroid hormone production is seen by squamous cell cancers. Now coming to adeno cancer. So adeno cancer MCQ points. So very important topic. Please focus. All MCQs are very important. Most common type worldwide. Most common in females. Most commonly peripherally located. It is mostly located peripheral. An interesting point is this is the tumor which can produce lung-to-lung mets. Peculiar lung-to-lung mets. From one lung to another lung mets is produced by adenocarcinoma. It is comparatively good prognosis. It is having a good prognosis. Not better than squamous cell cancer, but it is having a good prognosis. It has good prognosis. Not so nice like squamous cell cancer, but good prognosis. That is a classification system for adeno cancer in those days known as Noguchi classification. Noguchi classification system was there in those days. Now we are using only TNM. Noguchi classification was an old classification system of adeno cancer. So please don't forget adeno cancer. Coming to the small cell cancer now, the most dangerous cancer. Small cell, also known as wart cell. Full of MCQ points. Small cell cancer is the most aggressive form. Aggressive cancer, worst prognosis. In spite of aggressive and worst prognosis, the interesting point is this is the only guy who responds to chemotherapy and radiotherapy. Both it is responding well. Other cancers will not respond. Chemotherapy and radiotherapy, small cell cancer responds well. And it is the one which produces extrathoracic mets, brain mets, liver mets, etc. Extrathoracic mets are very common. It is the one which is producing paraneoplastic syndrome most common paraneoplastic syndrome is produced by small cell cancer because of the following substances produced. Ectopic ADH production. Ectopic ACTH production. ADH production produces syndrome of inappropriate ADH production, SIADH, resulting in hyponatremia. Syndrome of inappropriate antidiuretic hormone causing hyponatremia. Ectopic ACTH causes hypocalcemia and Cushing syndrome. And they also get myasthenia gravis like Eaton-Lambert syndrome. Like myasthenia gravis, there is a syndrome known as Eaton-Lambert syndrome, and they can develop cerebellar degeneration. So interesting point, please don't forget, for small cell cancer, the major problems are with small cell cancer: ADH production, ACTH production, Eaton-Lambert syndrome, cerebellar degeneration. All these are paraneoplastic syndromes seen in this case of small cell cancer. Finally, the last cancer, large cell cancer. So large cell cancer is mainly producing one interesting paraneoplastic syndrome. That is what? Galactoria, due to excessive prolactin production, galactoria in females. And in males, it produces gynecomastia. In females, it produces galactoria. So these are the classical paraneoplastic syndrome of large cell cancers. So now let us only tell about the paraneoplastic syndrome one by one. In squamous cell cancer, what is the paraneoplastic syndrome? It produces ectopic parathyroid hormone. Therefore, it produces hypercalcemia, hypophosphatemia, and also produces clubbing. Please remember, clubbing is also a feature of squamous cell cancer. When you come to adenocarcinoma, there will be, what are the paraneoplastic syndromes? There will be DIC, hypertrophic pulmonary osteoarthropathy. So paraneoplastic syndrome of adenocancer is hypertrophic pulmonary osteoarthropathy, and migratory thrombophlebitis. What is this sign known as? Migratory thrombophlebitis is known as Trousseau's syndrome. All these are seen in adenocarcinoma. DIC, hypertrophic pulmonary osteoarthropathy, and migratory thrombophlebitis. But when it comes to small cell cancer, there will be SIADH, ACTH production, myasthenic Eaton-Lambert syndrome, and cerebellar degeneration. In large cell cancer, there is galactoria and gynecomastia as features. So these are the various features of various lung cancers. And last NEET PG 2020, they asked the T staging of lung cancer. So I'm going to discuss about T staging of bronchogenic cancer because this is asked in NEET PG 2020. So T1, so tumor size is less than or equal to 3 cm. Tumor size is in the lung is less than or equal to 3 centimeters, and it is involving lobar bronchus. That lobe bronchus involved, but not involves what? Not involves main bronchus. So not involves main bronchus. It involves only lobar bronchus. Less than 3 cm involves lobar bronchus. In this, there is T1A, T1B, T1C. Each one is 1 centimeter. 1 centimeter, 1 to 2, 2 to 3, like that. So each one is 1 centimeter increased. T1 is less than 1 centimeter. T2 is, so T1A is 1 centimeter. T1B is 1 to 2. T1C is 2 to 3 centimeters. Coming to T2, tumor size is 3 to 5 centimeter only. So less than 3 to 5. In this, what happens? Main bronchus involved. So T1, main bronchus not involved. Here, main bronchus involved, but not involves carina, but not involved carina. And if definitely the main bronchus is involved, there will be lung atelectasis. There will be obstructive pneumonitis. Atelectasis and obstructive pneumonitis may be present. And it may involve the pleura, only pleura. It involves only the pleura of viscera. Visceral pleura is involved, not the parietal pleura. It involves only the visceral pleura. This is T2. T2 is 3 to 5 centimeters. T3 is more than 5 centimeters up to 7 centimeters. So there, here, everything which I told you not involved previously will be involved here. It will involve the carina. It will involve the parietal pleura. It will involve the chest wall also. Chest wall also will be involved. It will involve the phrenic nerve also. So everything which I told you not involved in previous staging will be involved here. It involves chest wall, parietal pleura. It involves parietal pericardium also. Parietal pericardium also is involved. So this is 5 to 7 centimeter. T4 is more than 7 centimeter with involvement of satellite nodules, satellite tumor nodules, and infiltration into esophagus, inoperable points, esophagus, trachea, heart, vertebra. So recurrent laryngeal nerve, all this, and also carina. Actually, carina is involved in T4, not in T3. It's not involved in T3. So please type it out in T3. It is involved in T4. It is involved in T4. Carina is involved in T4. So involvement of carina, involvement of trachea, esophagus, heart, vertebra, RLN, all these are signs of inoperability. All these lead to inoperability. Satellite tumor nodules in the same lobe, in ipsilateral lobe, it is T4. If nodules go to the opposite lobe, it becomes metastasis. So please don't forget T1 is less than 3 cm with involvement of lobar bronchus. T2 is 3 to 5 cm with involvement of main bronchus with atelectasis with visceral pleura. T3 is parietal pleura, parietal pericardium, chest wall, phrenic nerve. T4 is involving the recurrent laryngeal nerve. So this question they have asked in exam, so I have to put it. So otherwise, this staging I never used to take in classes in previous year and all. This year, since this question has come, I have put this. Please remember this. Non-invasive investigations. What are all the non-invasive investigations for lung cancer? We take a chest X-ray. Okay, chest X-ray. The chest X-ray can detect most lung cancers. So many lung cancers can be detected by chest X-ray. It will show you the atelectasis, collapse of lung, everything can be detected on chest X-ray. If you have a doubt, we have to go on with the CT thorax. So this is the first investigation if you suspect lung cancer. The first investigation to be done if you suspect lung cancer is CT thorax, and you have to assess for lung resectability. We have to look for lung resectability, and if any nodes more than 2 cm is metastatic node, in the mediastinum any node more than 2 cm is said to be metastatic, and usually we advise PET CT for these patients. PET CT is advised. Sputum cytology can be done. Sputum for cytology can be done. These are all non-invasive investigations. Sputum cytology, PET CT, all these are non-invasive, and which we are not doing any major procedures. Invasive procedures. We have to do bronchoscopy and take biopsy. Bronchoscopy, we can directly enter into the lesion and take biopsy. Transbronchial or transbronchially, we can take needle biopsy from the tumor. So we need to, by invasive investigation, we take biopsy. Or we can do endobronchial ultrasound and biopsy, like an endoscopic ultrasound, endobronchial ultrasound, or we can advise CT guided biopsy. All these are invasive investigations. But the problem with the CT guided biopsy is there is chances of pneumothorax. There is chances of pneumothorax. Therefore, bronchoscopic biopsy is better. There is no chances of pneumothorax. Okay. So CT guided biopsy is usually advised for peripherally located tumors, not for central tumors. Peripheral tumors we can go for CT guided. Central tumors we go for bronchoscopic biopsy. Central tumors. So peripherally located tumors like adenocarcinoma and other cancers, we can take biopsy CT guided. Okay. So there are some methods in which surgically we take biopsy. Surgical methods of taking biopsy. Surgical methods. Everything is there in Bayesian law. Surgical methods are mediastinoscopy. Mediastinoscopy. So please remember mediastinoscopy. Under general anesthesia, we put a transverse incision here above the sternal notch. So if this is a patient, under general anesthesia, you put a transverse incision above the sternal notch like this, and through this we pass a scope inside. Through this mediastinum, we pass a scope inside, and we take biopsy from the subcarinal nodes. From the carinal nodes or paratracheal nodes, we can take biopsy. So paratracheal, subcarinal node biopsy can be taken through mediastinoscopy. It's a surgical procedure. Therefore, there is chances of pneumothorax and bleeding. Pneumothorax can happen, and also bleeding can happen in this procedure. Pneumothorax and bleeding can happen in this procedure. Please don't forget, this is mediastinoscopy. Mediastinotomy. Mediastinotomy. Mediastinotomy is by making an incision in the second intercostal space. In the second intercostal space, we make an incision, and by this method, we can go and take mediastinal nodes. We can take biopsy from the mediastinal nodes, especially left para-aortic nodes are taken. Left para-aortic nodes, biopsy can be taken by mediastinotomy. But none of this is needed now. Mediastinoscopy or mediastinotomy is not needed because we have the latest BATS, video assisted thoracoscopic surgery. We can stage the mediastinum, excellent method. Staging of mediastinum is now by BATS. So there are 3 types of investigations: non-invasive investigation, invasive investigation of biopsy, CT guided biopsy for peripheral tumor, transbronchial biopsy for central tumor, surgical is by mediastinoscopy, mediastinotomy, and BATS are the various methods to take biopsy. Please don't forget these points. And coming to the management of lung tumors, management of lung cancers, how will you manage? Cancers is best answer is surgical excision. Surgical is the best management whenever possible. Surgical is best. Okay, surgical is best whenever possible. But for only small cell cancers, we can give chemotherapy is available. Chemotherapy can be given only for small cell cancers, not for all cancers. Only for small cell cancers, chemotherapy is effective. 90% regression will be seen. In spite of being a bad prognosis, 90% regression is seen with small cell cancers. Okay. For N2 cases, extensive node in the mediastinum patients, we have to give neoadjuvant chemotherapy. Neoadjuvant chemotherapy is advised. And for adenocancers, now they have introduced one new, for only for adenocancers, now they have found out oral tyrosine kinase inhibitor, known as geftinib. So oral tyrosine kinase inhibitor, we can use geftinib. So this is used for adenocancer, especially it is beneficial in adenocancer. Please remember this from Bayesian law. Geftinib, it's an oral tyrosine kinase inhibitor used for adenocancers. Single agent chemotherapy like this can be useful for old patients, very old patients. We can use single agent therapy like this. And when you come to surgical treatment, there are multiple modes of treatment. So we all know very well there are multiple segments. If I remove one segment with its blood supply, with its pulmonary artery and bronchial vessel, etc., if I remove only this, it is known as segmentectomy. If I anatomically remove a segment ligating its pulmonary artery, pulmonary vein, and bronchus, if I ligate pulmonary artery, pulmonary vein, and bronchus of that segment and remove it, it is segmentectomy. If I put a stapler like this and remove that part of lung without any proper anatomy, that is known as wedge resection. So wedge resection, segmentectomy. So various options I'm telling. Either you can do wedge resection, or you can do segmentectomy, or you can identify only the specific lobe, the lobe which is involved. So among the upper lobe means if this upper lobe is involved, we can only remove this upper lobe. This lobectomy, this is known as lobectomy. Lobectomy is possible for early cases of cancer, early cancers. For early cancers, we can do lobectomy. The bronchus is stapled or sewn because that part bronchus is little big bronchus. It can go for leakage. So bronchus is stapled, and we usually keep ICD 1 or 2 ICDs after surgery. We have to keep 1 or 2 ICDs after surgery. So please don't forget lobectomy. Another last operation which we do is a major operation in which we remove the entire lung. That is known as pneumonectomy. So pneumonectomy. So please don't get confused. Segmentectomy is there are multiple segments. If you remove only one segment, it is segmentectomy. If you remove one lobe, that is lobectomy. If you remove the entire lung, whole lung, it is pneumonectomy with a mortality rate of 5%. It has a mortality of 5%. So usually this is a major surgery. After removing this lobe, the total lung, this area will be blank and there will be flowing fluid will be collected in this place. And this empty space will be filled up with fluid gradually. Until that, we will usually put an ICD for a temporary period. ICD is put, slowly there will be, that empty space will be replaced by fluid. So pneumonectomy is contraindicated for tumors involving aorta, heart, or esophagus. Heart or esophagus, if the tumor is infiltrating, we don't do this operation. Please remember this point, we will not do, if it is involving heart or esophagus or aorta, we will not do a major surgery like pneumonectomy. So these are the basic points in lung cancer. So lung cancer is a very important point, please don't forget it. Okay, so I will review it when I'm discussing the MCQs. Again, I will review this topic. Squamous cell cancer prognosis. 5-year survival of squamous cell cancer is around 35 to 50% will have 5-year survival. Adeno cancer will have 25 to 45%. 25 to 45%. Small cell has only 5% worst prognosis. So best is squamous cell cancer, second common is adeno cancer, worst is small cell cancer. Prognostic factors. These are the prognostic factors from 5-year survival of these cancers. Okay, please don't forget these points. And finally, in this thoracic chapter, the last thing is chest wall anomalies. The chest wall, going for the chest wall ribs, no, the medial sternum and the ribs, chest wall anomalies. We have two important anomalies. One is pectus excavatum. What is the other name of pectus excavatum? Pectus excavatum is a condition in which the sternum is looking like a disc shape. This is disc shaped. Disc shaped sternum is known as pectus excavatum. Another one is in which the sternum is protruding out like this, known as pectus carinatum. So pectus excavatum is the sternum is going inside. So the patient looks like this. Excavatum. PGN chest is carinatum. The chest is looking outside. It is PGN chest. So both will have high cosmetic irregularity here. So pectus excavatum is a disc-shaped deformity, carinatum is a PGN-shaped deformity. They don't cause respiratory problems and all, just cosmetic problems. So for this pectus excavatum, we can do open operation known as ravage procedure. Please don't forget, this question can come in the exam. So ravage procedure. So open operation, you resect the sternum and ribs and reconstruct. You resect the sternum and ribs and reconstruct. Ravage. Or you can do a minimally invasive surgery known as NUS procedure. I'll show you the picture of NUS procedure. We keep a metal bar behind the sternum. We keep a metal bar, long metal bar behind the sternum known as NUS procedure. So ravage procedure is an open operation. NUS procedure is a minimally invasive surgery. Okay. So pectus excavatum and pectus carinatum, both of these guys will need surgery. So let me show you the images of these points as an exam. So what is the most common mediastinal mass according to William Love? It is thymoma. Correct answer is neurogenic tumor overall. But for a national board exam, go with thymoma. AIMS exam, go with neurogenic tumors. So thymoma, it is common in anterior mediastinum. Please remember, this is thymoma seen in the anterior mediastinum. It will have a well-defined capsule. To differentiate it from lymphoma, lymphoma will have associated nodes, but thymoma will be solitary. It will have a well-defined capsule, and the most common paraneoplastic syndrome is myasthenia gravis in thymoma. And please don't forget the syndrome of Masoka staging. Masoka staging, please don't forget. Okay. So total thymectomy with sternotomy is done for these patients. Total thymectomy with sternotomy is done for these patients. So please remember, the total thymectomy with the sternotomy is done. So myasthenia gravis is treated by anticholinesterase drugs in thymoma. So bronchogenic cyst, can you tell me where is the bronchogenic cyst common? Bronchogenic cyst is common on right side lung, lower base. Sequestration is common on left side, more common than right side. Left lower lobe. Bronchogenic cyst common on right lower lobe. Lung sequestration common on left lower lobe. Okay. So this is a extra lobar sequestration. You can see this is known as Rokitansky lobe. Intralobar sequestration is having communication with the biliary tree. So chylothorax we have discussed, and we have discussed porous triangle. You can see the porous triangle here, bounded between arch of aorta, left subclavian artery, and the vertebra. So vertebral column, arch of aorta, left subclavian artery. We have the thoracic duct going and draining here. We have to go and ligate at this point. This is porous triangle. So lung tumors, you can see the popcorn calcification of the pulmonary hamartoma. So bronchogenic cancers, we have discussed all the points. Please remember all the points. The most common mutation is KRAS mutation. And please don't forget, this is a classical picture of Pancoast tumor. You can see the patient having a tumor on the left lung apex, and this patient is having ptosis, meiosis, and hydrosis. So this is a picture showing you ptosis, meiosis, and hydrosis. So please don't forget, squamous cell cancer is mostly central in location. It can cavitate. Adeno cancer is peripheral in location. It can metastasize to opposite lung. Small cell cancer is the most common, causing extrathoracic mets. So large cell cancer can cause gynecomastia. Please don't forget the paraneoplastic syndromes. I told you small cell produces ADH, ACTH. Squamous cell cancer produces parathyroid hormone. Okay, therefore parathyroid hormone causes hypercalcemia and hypophosphatemia in squamous cell cancers. So please remember the staging: less than 3, 3 to 5, 5 to 7, more than 7. So this is size less than 3, 3 to 5, 5 to 7, more than 7 centimeters. Various investigations we discussed, and please don't forget the drug geftinib is the oral tyrosine kinase inhibitor approved for non-small cell cancers. So the lobectomy, segmentectomy, lobectomy, pneumonectomy, all these points you should not forget. So this point I want to tell: drainage of the space after pneumonectomy, no suction is applied. Only keep an ICD and leave it unclamped, or unclamp it for 1 minute every 1 hour. So every 1 hour you unclamp it. So slowly the fluid will fill the space, and the pneumonectomy space is filled with fluid. Okay. So MCQ points I want to tell in this: most common type overall is adeno cancer. Most common type in non-smokers is adeno cancer. Most common type in females is adeno cancer. Most common type in smokers is squamous. Most common type in India is squamous. Most common type associated with SVC syndrome is small cell cancer. Most peripherally located tumor is adeno cancer. Peripherally located. Noguchi classification is for adeno cancer. See, all are one-liners. Centrally located cancers are small cell and squamous cell. Small cell, squamous cell are centrally located. Pancoast tumor is a squamous cell type. Paraneoplastic syndromes are more common with small cell cancer. Worst prognosis is seen with small cell cancer. Most common site of metastasis is liver. From lung, where does they go? Distally means lung mets are common. Most common endocrine organ involved is adrenal. Lung cancer is most commonly metastasizing cancer to heart. We have discussed no myocardial secondary, most commonly from lung cancer. Okay. Brain mets may present with a neurological deficit. CA lung is most common primary for all the cancers like kidney, esophagus. CA lung is most common primary for mets from kidney, esophagus, pancreas, spleen, liver, adrenal, brain, skin. All this will produce lung mets commonly. So we'll discuss that. This is a typical pectus excavatum, disc shape. This is pectus carinatum, PGN chest. We have to do surgery like this. Name the procedure shown here. We kept a metal rod for a patient who is having a pectus excavatum by a minimally invasive procedure known as NUS procedure. This is NUS procedure. So ravage is an open procedure. NUS is a minimally invasive procedure for this condition, pectus excavatum procedure. So patient presents with Horner syndrome, X-ray test is shown here. So answer is squamous cell cancer. So now the same picture I already discussed. Patient has ptosis, meiosis, and a tumor. So this is a typical Pancoast tumor. So what is the significance of this triangle shown here? Anteriorly bounded by lateral border of pectoralis major, latissimus dorsi posteriorly, apex, and fifth intercostal space aligned. This is a line safety triangle to put ICD. This is safety triangle to put ICD. So what is the name of this valve? It's a very interesting valve. Please remember, in a pneumothorax, usually we put a tube like this and we connect it to an underwater drainage like this. In a pneumothorax, we connect it to underwater drainage, the air will be slowly bubbling out. Instead of connecting to underwater, after putting an ICD, we can connect this valve. It is having a one-way valve. It allows the gas to come out, but don't allow the gas to come inside. So this acts as a one-way valve. So what is the name of this valve used in pneumothorax? This picture is taken from Sadistan. This is Heimlich valve. Heimlich valve is a valve used in pneumothorax. Pneumothorax valve used is Heimlich valve. Instead of underwater drain, we can use this Heimlich valve. Peculiar lung-to-lung mets is seen with adenocancer. Commonest site of extragonadal germ cell tumor is in the mediastinum. Extragonadal germ cell tumor, common site is mediastinum. Small cell cancer, the following are elaborated except, which is not elaborated. They have ADH, ACTH, calcitonin also, except noradrenaline. Early stage of non-small cell cancer can be managed by early stage or advanced stage. We can do breast cancer with surgical resection. If it is an advanced stage, we have to do surgical resection, and chemotherapy is less effective in non-small cell cancers. If it is a small cell cancer, we can do surgical resection with adjuvant chemotherapy. Okay. Jeftinib is used in non-small cell cancers. Jeftinib, oral tyrosine kinase inhibitor. This is a NEET PG 2020 question. Which of the following is not a component of Thorax score? Which of the following is not a component of Thorax score? Thorax score is a score given in Bayesian law based on 9 variables to predict the morbidity after surgery. So Thorax score is most widely used model to assess the risk of operative mortality in thoracic patients. So in thoracic surgery patients, to assess the risk of death, we use a score known as Thorax score. It is based on 9 variables. I kept a mnemonic for this: as soon as possible, plan doctor CME. So A for age, S for 6, another A for American Society of Anesthesiologists score, performance score. So see, age and 6 comes first. The next two are decided by the anesthetist, performance score and anesthesiologist score, and priority of surgery, dyspnea score, comorbidity score, malignant diagnosis, and extent of surgery or extent of duration of surgery. So these all will come under these 9 variables. With these 9 variables, we make a score known as Thorax score. This question came first time in NEET PG 2020. Since it is a favorable question for national board examiners, you can again expect this question. So please don't forget, as soon as possible, age 6, American ASA grading, performance score, plan means P for priority of surgery, D for dyspnea score, comorbidity score, malignant diagnosis, and E for extent of surgery. So in this, performance status is there, ASA grading is there, priority of surgery is there, complication of surgery is not there in the scoring. Which of the following is not a component is complication of surgery is not there, because it is actually a score, preoperative score. This is actually a score which is planned preoperatively. So before going for surgery, the extent of surgery, for example, if I'm going to do a pneumonia, it will take 4 hours. Like that, with all these things, we plan the mortality in the patients. So the mortality scoring prediction is with the help of Thorax score. So please remember, so this cardiothoracic surgery chapter is a high yield chapter. So recently there are 2 questions. Last NEET PG 2020, we got 1 question from lung cancer staging, and we got another question from Thorax score. So please focus this chapter. Since this is recently asked more, I have focused in depth on this chapter from Bayesian law. Thank you.